Well, thank you very much. Thank you so much for the invitation. And the invitation to be able to travel like Star Trek by teleportation all the way to Indonesia in the matter of a few minutes, a few mouse clicks. Anyway, I think what I'm going to talk about is a little bit like Star Trek and teleportation. If you were to think about how ophthalmology was even in the 1980s, when refractive surgery meant RK. So I'm going to go through a rather dense whirlwind tour of all the procedures. And I'm going to highlight where some of the marketing speak is false and leads people to believe that certain procedures are better in general than others. And I hope to put the science all together so that I can then show you what it is that we do at our clinic and how we practice and what procedures we choose when. So in terms of my financial interests, I'm a consultant for Carl Zeiss. I've been their lead consultant for 20 years. And so I'm going to talk about, topography guided treatment and SMILE and, the use of the MEL laser. But I also, as many of you know, kind of was the first person to get interested in measuring epithelium. And 20 years later, others started to get interested. And 25 years later, there was a commercial device on OCT. So I have a financial interest in ultrasound. But I hope to show you how so ICL sizing is helped by ultrasound, as well as how epithelial mapping has taught us a lot about the science. And, the whole point here is bias, right? I wrote an editorial on bias in the JRS when George Waring was asked to sit down as chief editor. Simply because he was a consultant for NIDEC. And, I think it's very important to disclose one's bias so that it's clear for the audience where, they can question what I'm saying. And I look forward to those questions during the question and answer session. So I'm going to go through these options because these are really the popular names on the block. And let's start with PRK. And specifically, let's start with TransPRK. Now, in order to understand TransPRK, we have to understand the epithelium because we're going trans-epithelially. And it wasn't until 2008 that the first publication of the three-dimensional pachymetric anatomy of the epithelium of the human cornea in vivo was published. And this is what we published. And as you can see, we found the same thing that everyone knew, which was that the epithelium was about 50 microns thick in the middle. But we described for the first time that there was a pattern of superior thinning by about 6 microns and nasal thickening of about 1 micron. We also showed that this pattern had an anthropomorphism. In other words, there was a mirror symmetry. And the simple explanation for this was something that I had published and talked about in 1994 when I started looking at the epithelium, which was that the eyelid forces combined with the outgrowth forces of the epithelium are what lead to this stable epithelial curvature, which makes glasses work from day to day. Well, here are 15 profiles from that publication taken at random, and we can see that this is normal eyes, never had surgery before, and these are the eyes that some companies are saying trans-epithelial PRK is the best procedure for all eyes. And I'm just going to pick a couple at random. Here is an epithelial profile which clearly will induce positive cylinder into this cornea. So you're going to induce astigmatism because there's going to be breakthrough of the epithelium top and bottom and not along this saddle. Here's another example where there's going to be an overcorrection because there's going to be breakthrough of the epithelium first in the middle and then less in the periphery. So there's going to be essentially a hyperopic shift in the program being done. So we showed in ARVO in 2011 with a very laborious method that the epithelial power was only 0 in a quarter of the eyes. It was within a half diopter in 60% of eyes, but 31% of the eyes had a positive epithelial lenticule, and 10% had a negative epithelial lenticule. So already you can see that trans-epithelial PRK is going to induce unknown and random refractive errors into the cornea. So this is one of the reasons why back in 1998, when Don Johnson first described transepithelial PRK, he called it no-touch PRK. I thought it was a bad idea, and they actually published a paper and concluded it was a bad idea and stopped doing it. But nevertheless, I'm going to show you there's a lot of literature on this, because TransPRK is say, well, it's better because the outcomes are better. There's less haze, there's less pain, there's faster recovery. Okay, so I went through and looked through the entire literature on studies that compared alcohol-assisted versus TransPRK. Here are 4 of them. The green boxes are the ones where TransPRK is better. Gray means the same, and the red box is where alcohol is better. So as you can see, and this is the last set of studies. So when we analyze all of them together, we see that, in fact, TransPRK is not better for the outcomes. 3/4 of the studies showed that they were the same. It wasn't better for haze, but it does seem to have had an advantage in pain and visual recovery. And that's understandable. You're only taking the epithelium out of the actual zone where the ablation is taking place. But when we look at the advantage from a wavefront standpoint, and the great David Kang from Korea asked me to help with the editorializing of this article, but we looked at transepithelial PRK with a wavefront guided system. In other words, trying to treat the wavefront at the same time, and we compared that to simple Munnerlyn-based smile. And we found that the efficacy was no difference. And this is contralateralized, by the way. So we found that there was no difference in safety. We found there was no difference in accuracy at all. And we found that there was no difference in astigmatic correction. And we did find that there was more spherical aberration induced by PRK than by SMILE. A little bit more coma by SMILE, but overall more higher order aberrations induced by transepithelial PRK. Now, there's one study that compared TransPRK with LASIK, and they found in their conclusion that they were the same, right? It says that they were both the same, about the same, within 0.5 diopters of target refraction. And you know what they say about statistics. There are 3 things that you can say about statistics, right? So let's look into the statistics of this paper. What we find, if you look carefully, is that in the transepithelial group, basically the nomogram was slightly overcorrected, which, as you know, means that more people see 20/20, because if they're slightly hyperopic, people see through that. And disadvantaged was the femtosecond LASIK group, because they were slightly undercorrected, and you can't see 20/20 through a -1/4. So but the most important thing to look here is that the standard deviation of the mean post-op was much higher in the TransPRK group, both for spherical equivalent and for astigmatism. Now, if you then go to that paper and look even further and actually look at the attempted versus achieved graph, you see the truth. The truth is that the blue dots, which is TransPRK, is way more outliers that are blue dots than red dots. And so, again, the science, 2008, which preceded this paper by 12 years, would have already told you that TransPRK was going to be less accurate, and yet we have 12 years of marketing-driven, unscientific wildfire going through the ophthalmic community, in a way that could have been avoided. Now, let's just remember that it wasn't 2008. I had not published these 3-dimensional profiles. I already knew in 1998 that the epithelial profile was going to cause this. And Dr. George, who actually worked with before Don Johnson died, he's the one who wrote all these papers up. And he admitted that regular PRK removing the epithelium was better than TransPRK. So let's move on to the second wave of marketing-driven drivel, which is this wavefront guided concept. And one of the biggest problems with wavefront guided surgery, as it was in that system that proposed it, was that it always centered all of the ablations on the center of the pupil. And I've talked about this for years, but let me just show you some examples of patients treated on this system that forces centration on the pupil for hyperopia. And you can see the angle kappa here, and you can see the decentration. The machine does a beautiful job of centering the procedure on the pupil, but a terrible job of giving the patient good optics centered on their own visual axis. And this is, all over the place. I can show, patients were enhanced because the result wasn't good. And of course, they were enhanced still in the center of the pupil, just hammering the result into the wrong place. So this is something which has kind of, I think, been put to bed in the literature. There are a lot of other investigators now who have confirmed that centration on the visual axis is ideal. But let's go back to this question of wavefront guided. And here's the thing. So this is 280 eyes measured in about 200 to 2004, and with the COAS, very high resolution wavefront sensor. And you can see the average aberrations of the normal eyes about to have LASIK or SMILE or PRK, sorry. No aberrations. Why would you put a tiny bit of a zero, like an empty nothing sandwich of aberrations on an ablation profile? When in fact, what we're really doing is inducing a lot of aberrations by the ablation profile. So the first attempt at wavefront guided by the companies was to take these Munnerlin equations and then take this magic wavefront fairy dust and pop it onto the ablation and do that on the cornea. And what did they find? They found that the results were worse than the results of conventional treatment without the wavefront. What did they find? They found that the aberrations went up, not down. They found that the spherical aberration went up a lot. And this is what other investigators were finding, and other investigators like myself with Meditech and then Carl Zeiss, we were looking at controlling the spherical aberration induction because that was the big problem as far as we're concerned, not the fairy dust. And so we were working on what was called aspheric profiles, adding more peripheral ablation to reduce the induction of aberration. That was the key, because the little sprinkle on top gets lost in the soup compared to the amount of aberrations that we were inducing in spherical. So then the debate got into the podiums and the academy and the ASCRS and the ESCRS. Oh, wavefront guided is because now wavefront guided number 2 was aspheric profiles with fairy dust on them. And they were saying, it's better than wavefront optimized. And the optimized people were saying, you don't need to do the wavefront guided. Only in a few patients that have high levels of higher order aberrations would need them put in. Otherwise, it's just random. And guess what? They were right. Wavefront optimized and wavefront guided are the same, except for very few cases where the higher order aberrations are abnormally high. But as you can see, it's not very many cases. And I will come to that. I will come to that now with topography guided, because now another marketing wave is coming through saying that all treatments should be topography guided. And one of the major excuses is that it allows you to center on the visual axis. Well, you can do that without a topography guided treatment. That's I've got news for you. But the MEL 70 from Meditech was the very first topography guided system to arrive on the market. I used that. I also then, of course, progressed onto the MEL 80, 2005, with the corneal wavefront guided with topography guided energy adjustment. And I've published extensively on this for zone enlargement and recentration. And, these are highly successful treatments in appropriately selected patients. But let's think about what the components are of the manifest refraction. You've got the anterior cornea, you got the posterior cornea, you got the lens, and you got the retina, which might have an astigmatic shape or a coloboma or something. And then you got your neural adaptation to your aberrations. So people might be fully adapted to an aberration that you then remove from the cornea, and then it's an unexposed adaptation. And the reason why I never went into doing primary topo-guided treatments for everyone, even though I could have since 2005, is because I read this paper by Pablo Artal in JV, where they showed in 2001 that if you combined the internal aberrations with the corneal aberrations, the whole eye had less aberrations. In other words, the cornea and the internal aberrations were mirror images of each other. So if you remove the corneal aberrations, you're going to increase the total eye aberrations, if you like, exactly as I was saying. So the final big thing which the Wavefront guided topography guided for all camp is having trouble with is choosing which axis of cylinder to use, because topographic cylinder and refractive cylinder are not always the same. Noel Alpen's called that ORA, and vector planning is a mystery as to why you should go between the two when we're doing refractive surgery. So all of these components, the internal and the corneal, and which ones to use between what and where is, I can tell you right now, that is not a solved mystery yet. Not in the slightest. So let me give you an example where I do use topography-guided treatments. And, here's a 47-year-old male who came in because he was complaining that that no one could prescribe a good pair of glasses for him. And he just always had ghosting through his glasses. And he had no refractive cylinder that he would accept, but you could see on his topography that he had an asymmetry, an inferior steepening. Now, it would, okay, so you say, well, we'll do topography-guided treatment. Well, hold your horses here. Is that a normal cornea? Well, let's take a look. Let's take a look at the back surface. Looks like it's normal. Is that definitive? No. The definitive way of proving that this is not keratoconic is to show that the epithelial profile is thicker where there is inferior steepening. You can miss early keratoconus by just looking at the back surface. So once I proved to myself that this was not a keratoconic cornea, I did a topography-guided treatment on this patient. I didn't change his best spectacle corrected vision, but I did do an ablation pattern that was asymmetric, and I did increase his contrast, and he did no longer have the ghosting problem, and we have data out to 6 years, nice and stable, looks great. Here's another example of a patient who had a sort of angle kappa-driven asymmetry of his cornea, and 2032 could have been because of the very high coma, right? Could have been. So we do a topography-guided treatment. We regularize the cornea beautifully on the visual axis, not the pupil, of course. We decrease the coma a lot, but we didn't increase the best spectacle corrected vision. The profile really did what it was supposed to do. And perhaps we might have, with this ablation profile, created a little bit of a difference in contrast sensitivity, or maybe that was just, luck. So again, optimizing treatments for the induction of spherical aberration is 98% of the game, and maybe 2-3% of human eyes have higher order aberrations that are worth putting into the ablation profile on a primary treatment. So again, marketing-driven wildfires through the ophthalmic community that are really not based on facts. Let's get to SMILE, because we're now talking about induction of spherical aberration. And I think Zeiss, was a little bit off the mark when they started marketing SMILE, because it left the cornea stronger and then stopped. Because what happened was some people started doing SMILE in formiformis keratoconus, thinking that because you leave it stronger, you can do what you can't. You can't. You cannot do SMILE in an eye that has formiformis keratoconus. We have 4 publications in the literature now proving that. The purpose of the increased corneal strength is to do with the optical quality. I'm going to show you the argument here. So we know that the anterior cornea is stronger than the posterior cornea, and that's been measured both by Brouillon microscopy and by laboratory, tensile strength measurement. So this is a well-documented phenomenon. We know from John Marshall that you can demonstrate that the strain in the cornea goes up more with a thicker flap than a thinner flap, and that it's the side cut that makes the strain go up, not the delamination. We know that. So SMILE is like a delamination with a little bit of side cut inside. So, not surprisingly, we used our mathematical model to show that the post-op relative tensile strength of the cornea in SMILE and a matched control of LASIK eyes, well, we have less change in preoperative tensile strength in SMILE than LASIK, and it's about 30% stronger, the cornea. Now, is that relevant? Well, it is, because if we look at these same eyes and we look at the optical zone that I used, well, in SMILE I was using 7 millimeter zones most of the time and 6 millimeter zones for LASIK. Why? Because of tissue constraints. And in SMILE we have the cap, which we can add to the bed, and that's the total uncut stroma. So looking at the induction of spherical aberration for this group, we know that the eyes that we did in a 6 millimeter zone induced a certain amount of spherical aberration, right? We know that at a 6.5 millimeter zone, we induced less, and at a 7 millimeter zone, we would induce even less. And now let's compare it to the matched controls done by wavefront optimized, wavefront guided systems. So in a 6 millimeter spherical smile, we would induce the same spherical aberration as a 6 millimeter wavefront optimized procedure. But with the smile, we'd be removing less tissue. A 6.5 millimeter smile would induce less spherical aberration than the LASIK wavefront optimized with equal tissue consumption. But a 7 millimeter zone smile induces a huge amount less spherical aberration than LASIK wavefront guided, wavefront optimized. Yes, with more tissue consumption, but still leaving the cornea 30% stronger. So the tensile strength of smile is not the reason for doing smile. The reason for doing smile is because of the tensile strength, you can use larger zones, which means you can get better optics. So there's less spherical aberration induction, and it's actually about 65% less spherical aberration induction with smile than LASIK if you matched controls. Others, of course, have shown much less aberration induction with smile than other procedures, and so this is not a surprise anymore. And then I'm just going to lastly, talk about the advantage of smile taking place below the nerve plexus, the anterior nerve plexus, while LASIK takes place, particularly now with the thin flaps that we make with femtos, it takes place in the nerve plexus. So if you look at the Cochet-Bonnet studies, all of the LASIK studies, and you see the recovery of sensation, and you look at all the smile studies, ours went out to 1 year, you can see that there's only a tiny little neuropraxis on day one, but corneal sensation is preserved really throughout the post-op period after smile. And we have beautiful, from Mario Nubile, we have beautiful images showing how the LASIK flap cuts the nerves, the flex cap flap cups the nerves. The smile cap still has nerves, but the smile cap has no nerves in the interface where the smile was created. And finally, I want to just show you that smile has an extraordinary accuracy. We published Kishore Pradhan, our fellow's outcomes from Tilganga, from -1 to -10, and he was a novice, and we're talking from his first eye all the way to his 1300 eye, and he had 95% 20/20. Our own outcomes that went into our smile textbook, 4,000 eyes, cylinder up to -9, a spherical equivalent up to -9, and you can see we had 95% 20/20, 2/3 of the patients 20/16, extremely good efficacy, very good safety, 0.08% of eyes losing 2 lines, and all of those had recovered either because they had line or an irregularity from irregular cutting that we treated with transepithelial PTK. And you can see an incredibly beautiful scatter of these 4,000 eyes with very, very high accuracy, 88% within a half diopter, all the way up to -10, and stability. So the cylinder correction, of course, very accurate as well with smile because we have cyclotorsion control. Contrast sensitivity actually slightly increased from pre-op to post-op, and really a phenomenal procedure. But of course, smile does have limitations, and we will need to move into an intraocular procedure called the ICL or other phakic IOLs that are coming down the line, copying the ICL. And I can show you like a simple series, 160 eyes, myopia up to -20 with cylinder over -6, and the refraction accuracy is just staggering. With this procedure because it's a piece of plastic, right? The cornea is not a piece of plastic. This is a piece of plastic. So when you put it in the eye, you get incredible accuracy and incredible safety. And of course, incredible night vision. So there's the scatter plot. Fantastic. It's almost like a one-on-one relationship. This is myopia up to -20, so there's a lot of refraction error involved here, and we still have 75% within a half. But all of the complications, or most of the important complications of ICL surgery had to do with the sizing. And that's something which I took a great interest in, and I was taught a lot by Carlo Lovisolo, and he gave me a lot of his time, and we worked together using high-frequency ultrasound to try and get away from the white-to-white sizing and to move into this sulcus to sulcus sizing realm. And we were using the Kojima formula with our high-frequency ultrasound Insight machine, expecting to get better results. But our real aim was to retrospectively analyze our data and make our own model to see if we could improve on just using sulcus to sulcus, and we did. We found, for the first time, this had never been discovered before, we would randomly found this, that something which I called the ciliary body inner diameter, which I thought was going to be a pointless measurement, but I stuck it in there anyway. Turns out that was the most significant variable for predicting the volt after surgery. And when we introduce scotopic pupil size, we actually have the ability now to predict each lens what it's going to do in the eye. And this gives us the ability to plan the volt of an eye, rather than just hope it's not too high or too low so we don't have to take it out. So I'm going to whirlwind show you that we had a training set of 42 eyes, and then we forward prospectively tested another 36, and then we reanalyzed and did another 69, and I'm going to show you this data very quickly. So here's our training set using the Kojima formula. Same ultrasound, same surgeon, same everything. And here is our volt control using Formula 1, and you can see Formula 2 just how much tighter the interquartile range is. But let's just mix all those two together so that we have a lot of eyes. And if we compare the mixed Formula 1 and 2 to all of the other, well-known formulas using OCT of the anterior segment, using anterior chamber measurements, and of course the star, we see that hands down we're able to get way better interquartile accuracy and much less outlier accuracy. So the chances of needing to do a lens exchange now goes down to, we think, almost zero. There's different reports of 1%, 2%, 5% of exchange rates. I know that Saldivar, who's put in 26,000 lenses, he says that 30% of the lenses are not at the volt height that he wanted the eye to have. And what does that mean? Well, you see, here's an example. Here's our formula, which is on our website, ICLsizing.com, which is free. Anyone can use it. It'll calculate all of the formulas for you at the same time. And our formula said this eye, we're going to choose a 12.6 because a 12.6 is going to give about 568 and 547. And what did we get? Well, we got 821 and 759. Okay, so we're off by less than 200 microns. But still, we're above what we predicted. Now, that's with the 12.6. Look at this. The star formula suggested a 13.7, and the 12.6 gave 820. So what do you think the 13.7 would have given? It would have given a guaranteed exchange surgery for that patient. So we avoided this exchange because the sizing based on posterior to the iris parameters is of course going to be more accurate than estimating the posterior chamber with anterior chamber or corneal diameter measurements. So the attempted versus achieved of our first formula was slightly skewed, but now we've got it parallel to the line. And as you can see, if we look at the percentage of eyes that are within 100 microns of intended volt, we have 60% of the eyes. And the next best formula is the Doherty, but obviously not as good. And you can see that compared to the anterior chamber OCT measurements, which are really not very good for predicting the volt, and certainly the star white to white, which is which is the oldest and least accurate. Let's face it, using high frequency ultrasound and posterior chamber measurements is the way to go if you want to avoid these lens exchanges, which harm more endothelial cells and are very traumatic for the patient psychologically. Our website is free for all to use. It is like the ISACRS calculator. You put all the numbers in, it tells you all the formulas, and you can compare them. So you're welcome to use that. And I just want to finish, therefore, by showing you how things are in our practice. So we don't do TransPRK for obvious reasons, but we do less than 1% PRK in our practice on primary procedures. We do Wavefront guided in 1 in 1,000. That's whole eye Wavefront guided. We do Topography guided in less than 1%. We do SMILE for 75% of our myopes, and about 1% of all of our surgeries need to be ICLs. Now, I want to finish with what I talked about yesterday, which is that this is the distribution of ametropia that I treat in my clinic. Here's a 3-year sample, and I want to point out that half the myopes are treated because of presbyond. most of the hyperopes are treated because of presbyond. And of course, the mixed cylinder and practically all the emmetropes are treated because of presbyond. These are the plano-presbyopes. So the presbyond, which I'm not including in this lecture, is actually the enabler for doing refractive surgery outside of the eye for presbyopia after the age of 40. So we don't have to do clear lens exchange on anybody. We actually can do presbyond, well, anybody. We do it on those people who are LASIK candidates, and those who are not LASIK candidates, which is 3%, those will get a lens surgery in our practice. So I hope that gives you an idea of how I have thought through our, scientifically, the arguments for where to go with which procedure, and I hope that will be helpful to you in the future.
All right. Thank you, Dr. Dan Reinstein, for beautiful presentations. Now, because of time, maybe I can take one question, only one question from Dr. Ruchita. What is your opinion about thicker cap is better in SMILE? What is your usual parameter for SMILE in your daily practice? Thank you.
So I don't like to talk about my preference because I want to talk about what is the standard operating procedure for SMILE. In other words, let's not talk about preferences. Let's talk about a standard that the whole world uses, and we don't, it's not a cacophony of rules here. Of course, the argument for using caps that are at least 130 microns thick is very strong. Because if you make the cap 130 microns thick, it gives you two advantages. It gives you the advantage of leaving the most corneal nerves in the anterior cornea preserved. So the benefit of SMILE is leaving the corneal nerves preserved, so you get less dry eye. But it also means that it is such a simple matter to do a LASIK enhancement in the 1% of eyes that require enhancement. Because no one wants to do PRK. No patient wants PRK. So you can do LASIK on top of the SMILE with a 100 micron LASIK flap inside your 130 cap. So those are the two strong reasons for using a thicker cap. Our go-to thickness is 145. And we'll reduce it down to 130 depending on residual stromal calculations and optical zones. But if we have to go below 130, we don't. Instead of going below 130 to 125, what we do is we jump to 90. Mm-hmm. So between 130 and 90 is no man's land. Why? Because if you make a 120 flap, what are you going to do? Create that as a flap and waste all that tissue later? No. What you do is you jump to 90, and then you use the Circle software to make that into a 90 micron LASIK flap. Anything in between, you're in no man's land. You're just wasting tissue and making the patient go through a PRK, which, as you see, I do very little of unless I'm doing therapeutic surgery.
Okay, thank you for your answer. Now we can move to Dr. Chang.
Better?
Yes.
Okay.
Yes.
You think I turned into a ventriloquist. So I'm going to answer that by turning it upside down. So what do we mean by which procedure gives the best contrast sensitivity? What we mean is which is the best quality of vision post-op, right? Because contrast sensitivity is a much more sensitive way of measuring visual quality than just a Snellen number. So the answer to that is the procedure which leaves the cornea with the least aberrations. Okay? So if we're going to pick out of all those procedures, that's going to be the ICL, right? Because the ICL doesn't change any of the aberrations of the eye. However, now you're introducing the risk of an intraocular complication, which we've just heard is unusual, but these things can happen and you have sizing issues. So we have to balance risk with benefit. And so we will not use ICLs in cases where we are perfectly capable of doing corneal surgery. And between the corneal procedures, as I hope I showed, and I think this is recorded, so I hope it'll be available afterwards for reviewing. I've demonstrated that, forget about the marketing. Each procedure has its place. And the eyes that have very high levels of higher order aberrations before surgery are very few, less than 5%, less than 3%, I would say. So in less than 3% of cases, is it beneficial to use a wavefront guided or a topography wavefront guided treatment? The other 97%, you're talking about a generic procedure which has wavefront optimization. In other words, it prevents the induction of spherical aberration. And of the procedures that we have, PRK, LASIK, and SMILE induces the least spherical aberration, and it does so because it leaves the cornea stronger, so you can use larger optical zones than you would have been able to under a flap. And because you can use larger optical zones, you induce less spherical aberration. I guess that's the short answer. The long answer, you have to listen to the talk again.
Okay, okay, right then. Thank you, Dr. Dan. Maybe we can proceed to the question for Dr. Chang. Dr. Dio, please.
Yes, thank you, Dr. Nasrul.